Hi, everyone. We're going to get started in a couple of minutes. We're going to give folks a chance to dial in. We have a lot of people calling in for today's webinar. So in the meantime, if you could put where you're calling from in the chat so I can see where in the world you are, that would be great. Okay, we're going to go ahead and get started. So hello, everyone, and thank you so much for joining us today. My name is Catherine Blackwell, and I'm the Chief Health Equity Officer for the Allergy and Asthma Network. Welcome to this afternoon's webinar. We are in for a real treat today with Dr. Regeneron Merchant as today's presenter. Now, we have a few housekeeping items before we start today's program. First, everybody's going to be on mute for the webinar. And we're going to record today's webinar and post it on our website within a few days. Now, you can find all of our recorded webinars on our website at allergyasthmanetwork.org. So all you have to do is scroll down to the bottom of the page to find our recorded webinars and pick the one that resonates with you and any upcoming webinars that you'd like to see. Now, this webinar is going to be an hour long, and that includes time for questions. So we're going to take these questions at the end of the webinar, but you can put your questions in the Q&A at any time you want. And the Q&A box is right down there at the bottom of your screen. And we're going to have someone monitoring the chat if you have questions or need some help. We're going to get to as many questions as we can before we conclude today's webinar. We're not going to be offering continuing education credits for this webinar, but we do have a certificate of attendance if you need it for your records. A few days after the webinar, you're going to receive an email with supplemental information and a link to download the certificate of attendance. We're going to also try to add the link to the certificate in the chat. So let's get started. Today's topic is biologics. What are they, how they work, and who might benefit? Now, a biologic drug is developed using cells from living organisms such as humans, animals, bacteria, and viruses. They target inflammation in the body at the source. And biologics are now available to treat all sorts of conditions, including asthma, allergies, atopic dermatitis, diabetes, cancer, and autoimmune conditions. In this webinar, we're going to learn all about biologics, how they work, and who might benefit from using them as a treatment. So it is my esteemed pleasure to introduce today's speaker, Dr. Regeneron Merchant. Dr. Merchant is an allergy, asthma, and clinical immunology specialist at the Woodland Clinic Medical Group, which is part of Common Spirit Health and Dignity Health Medical Foundation in Woodland, California. Dr. Merchant focuses on adult and pediatric seasonal and perennial allergic rhinitis, asthma diagnosis and management, food allergies, drug allergies, and immunodeficiency disorders. He is a fellow of the American College of Allergy, Asthma, and Immunology and won the Sacramento Magazine's Top Doctors Allergy Award from 2016 to 2022. Special thanks to Sanofi and Regeneron, who has provided funding support to make this webinar possible today. So, Dr. Merchant, thank you so much for being here, and I'm going to turn it over to you now.
Thank you. Good morning or good afternoon to those on the East Coast. I want to thank the Allergy and Asthma Network for allowing me an opportunity to speak to you during this webinar, again, titled Biologics, What They Are, How They Work, and Who Might Benefit. This webinar is part of the mission of the Allergy and Asthma Network outlined, which is to provide education on topics focused on allergic conditions. Before we begin, I want to also say happy Halloween to all. I am hoping this webinar will be a treat for you all. Today, we'll explore, again, cutting-edge approach to managing allergic disease. These therapies are revolutionizing how we treat conditions like asthma, atopic dermatitis, and many more by targeting the immune system's key inflammatory pathways. Most of these treatments have been around only over the last 5 to 10 years. And as we go through the webinar, there may be some things that feel spooky, but we'll try and keep it as simple as possible. Thank you, Catherine, again, for that initial introduction as well. As Catherine stated, I'm a practicing allergist. That picture of me might as well be from a costume from 20 years ago when I first started my fellowship in allergy. I have no financial conflicts or disclosures as to this topic. So let us begin. Over the course of this webinar, we'll break down what biologics are, some early biologic treatments that are still commonly used, and we'll talk about inflammation specific to allergic conditions, and finally review specific biologics and how these new biologics work and how they're transforming the treatment landscape for patients and who benefits. So what are biologics? Again, biologics are special medicines derived from living organisms or their components, proteins or cells, or genetically engineered material, which we'll get to. Biologics can either stimulate or inhibit specific parts of the immune system. These are usually large, complex molecules, and because of their size, require treatments to be administered as injections or infusions, compared to most traditional medicines that we take as oral treatments. And with, again, new technology and genetic engineering, we can now create specific biologics that target the immune system. This can offer a more personalized, precise treatment approach than traditional therapies. So specific types of biologics. Biologic treatment is probably as old as the field of medicine and goes back over centuries. These early treatments laid the foundation for current biologics, and biologics can be classified into several major current categories outlined here: blood products, vaccines, immunotherapy, hormones, and monoclonal antibodies, which will be the major focus of this webinar. So, blood products are some of the earliest biologic treatments. And as I'm looking at this slide, I'm wondering, why did I not put a vampire or some blood-sucking leech as a visual? But I digress. Specific to the field of allergy is the use of immunoglobulin proteins that fight infections. These treat immune deficiencies. Immunoglobulins were first documented use in 1952, approved by the FDA in 1980, and subcutaneous immunoglobulin treatment was approved just in the last 20 years and now considered the preferred method for treatment for immune deficiency disorders. Did you know vaccines and immunotherapy are also considered biologics? Again, these are designed to help the body develop or stimulate the immune response. Several forms of allergy immunotherapy are currently approved and used in everyday care. Subcutaneous immunotherapy, or more commonly known as allergy shots, were introduced over a century ago and among the first biologics used for treatment for allergic rhinitis. Venom immunotherapy, again approved back in 1979, commonly used for treating individuals with stinging insect allergy. Sublingual immunotherapy, more commonly used in Europe, but approved again for monoallergic treatment for ragweed, grass pollen, or dust mites, involves placing a small amount of the allergens under the tongue to build immune tolerance. And finally, we now have oral immunotherapy, which has been studied for several years in treating food allergy. Currently, we have one approved FDA OIT for peanut allergy that's been available for the last 4 years. So going back to our list, hormones are also classified as biologics, but we won't talk about that today. And so before we move to the last category of monoclonal antibodies, just a quick recap. Biologics have been used for centuries. the early history of biologics have included blood products, vaccines, and immunotherapy. And these treatments are still critical and used in disease management today. A lot of these treatments are also relatively new and exciting, and they've also helped lay the groundwork for understanding the immune system and many of today's biologics targeting specific immune system components. So today, biologics are more synonymous with monoclonal antibodies. And here we can see, again, sort of a graphic description or visualization of what these monoclonal antibodies look like. They first were developed back in 1970 to target, again, disease pathways with greater precision. The first therapeutic monoclonal antibody was approved in 1986 for transplant rejection. And again, this laid the groundwork for additional biologics that we use today in allergic conditions. So before we talk about, again, specific monoclonals, I want to share how to identify a monoclonal antibody. It's actually in the name, or specifically the end of the name. The drug, MAB, at the end of the name stands for monoclonal antibody. So if you see that as part of the drug name ending in MAB, that is a monoclonal antibody and what is commonly referred to, again, as biologics used in treatments. They are classified based on their source of where these antibodies were initially created or now genetically engineered. First, again, used in mouse development or used from mouse models to create the antibodies. And then more recently, we have, again, fully human antibodies that are now available for use. We can sort of see this in this visual. The mouse antibodies, when then having a chimeric antibody, a humanized antibody, and or a fully human antibody. And these are where most of our treatments now lie. And the importance of this is that as we use, again, foreign proteins or antibodies, these can actually stimulate your immune system. So the more closely they resemble our own human antibodies, the less immunogenicity that we can see as depicted. So one more piece of information that I want to talk about before we go into specific, drugs or monoclonal antibodies. Again, we've talked about or brought up the concept that the monoclonal antibodies target specific parts of the immune system. So to lay the groundwork, I want to explain what we are targeting. Understanding inflammation is the body's natural response to infection or injury. It involves, again, specific cells that with specific targets. And in allergic disease like asthma and atopic dermatitis, these responses become chronic and are considered to be harmful. So this is a really great slide, not scary at all. There's a lot of information on here, and you'll hear me repeat multiple times the targets of inflammation as we go forward. Inflammation, again, is currently broken down into 3 types, type 1, type 2, or type 3. And most of us are going to focus on this middle section called type 2 inflammation, which is what drives allergic disease. It's characterized by cytokines, primarily IL-4, IL-5, IL-13, and IgE, and involves specific cells called mast cells or eosinophils. And again, we'll go through these in subsequent slides. But again, this is the key piece of what we are targeting and how these biologics basically work. This slide shows, again, how type 2 inflammation is connected to many of the disease states that we have outlined. So asthma, atopic dermatitis, food allergy are now, again, all tied to or related to type 2 inflammation. It is central to the treatment paradigms that we are now able to use when we target the immune system. Again, all of this inflammation is driven by cytokines, which then involve specific cells, mast cells, or eosinophils. So now we'll go through a couple of specific monoclonal antibodies and the specific targets that are associated with those. Omalizumab, which was the first monoclonal antibody in the field of allergy, targets specifically IgE. We have mepolizumab, which again is a target for IL-5 and reduces eosinophils. Reslizumab also targets IL-5 and reduces eosinophils. We have benralizumab, which targets IL-5 receptor, so just a slightly different target, but also reduces eosinophils. We have dupilumab, which targets IL-4 receptor alpha, which then actually targets both IL-4 and IL-13. We have traclinomab, which is specific to IL-13, and one more monoclonal antibody, which is tezepelumab, which targets TSLP. This column on the right are the humanized antibodies, and this column on the left are what are the fully human antibodies that are genetically engineered today. Again, looks scary, but we'll try and continue to keep it simple and walk through how these drugs work and who will benefit. Oops. So what is asthma? Asthma is a chronic disease characterized by inflammation of the airways, leading to symptoms like coughing, wheezing, and shortness of breath, which we are all commonly familiar with. This inflammation, again, is triggered by allergens, infections, or environmental factors. Asthma currently affects about 25 million individuals. And biologics, again, block specific molecules that are involved in type 2 inflammation that reduces the airway narrowing, frequency of asthma attacks, need for oral steroids, and/or emergency care. This is a very nice illustration that, again, sort of depicts the inflammation in asthma, specific targets, IL-4, IL-5, and IL-13, as well as the cells, eosinophils, that I had mentioned previously, leads to increases in mucus production and smooth muscle hypertrophy, which are, again, the hallmarks of the disease or the inflammatory state. This slide, a little bit more detail. Again, not all of the details are important, but highlights a lot more targets. Specifically, we have IgE, which is related to allergy, and TSLP, as shown here. And as we understand or identify more targets, we can now classify the disease states in more detail for personalized treatment. So we have, what now is considered allergic asthma, or eosinophilic asthma, or neutrophilic asthma. These are terms that are, again, sort of gaining traction as we continue to identify or determine how inflammation is affecting the airways. We also are continuing to identify new targets, and that's where ongoing research continues to occur. And so who benefits from these drugs? Currently, the GINA guidelines recommend patients with about moderate to severe asthma that's not controlled at step 4 treatment, which is about 5 to 10% of all asthmatics. So up to about 5 million individuals can benefit from these drugs. And again, we can see that they've listed a whole bunch of them here as anti-IgE, IL-5, IL-4 receptor, and again, TSLP is not listed, but these are all, again, drugs that fall into the step 5 category. Similarly, for children 6 and older that are not controlled on step 4 on medium to high doses of inhaled steroids or long-acting bronchodilators, biologics are now considered or available for treatment. So a quick, again, summary of this biologics that are currently approved for asthma and when they were approved. Again, omalizumab being the oldest, about 2003, just as I was starting my work in the field of allergy. Benralizumab, again, I did a lot of research associated with it, approved, again, just over or under 10 years ago. And then dupilumab here, which lists approval back in 2010, was actually only approved for asthma in 2019. So it was actually initially approved for other clinical conditions. But as we go through, again, a number of these next few slides, we'll see that these drugs do have overlap. And so that's how these drugs have now gained additional clinical indications. Again, a quick recap of the specific targets. Omalizumab targeting IgE, mepolizumab and reslizumab targeting IL-5, benralizumab targeting IL-5 receptor, tezepelumab targeting TSLP, and then dupilumab targeting that IL-4 receptor, which affects IL-4 and IL-13. Again, hope these targets are starting to sound familiar. We're going to repeat it a couple more times as we go through a couple of more disease states. Next topic for treatment is atopic dermatitis. Again, a chronic skin inflammatory condition driven by type 2 inflammation, leads to itching, redness, skin barrier dysfunction, and can be triggered by food, environment, or infection. Here we see a nice illustration of, again, a severe case of atopic dermatitis involving the entire skin. So biologics, again, block or target the specific cytokines that we've talked about that cause the inflammation. This leads to improvement in the skin barrier function, decrease the flares or frequency of flares that individuals experience, as well as shown to improve quality of life. Again, a nice illustration that shows the inflammation in the targets that affect atopic dermatitis, IgE down here, TSLP right here in the middle, and IL-4 and IL-13, as well as, again, a number of other targets that we aren't going to focus on, but these are the primary ones that, again, are being used or have been developed for treatment. So who benefits? Again, about 10 to 30% of children and 2 to 10% of adults have atopic dermatitis. And similar to asthma, individuals with severe eczema, not controlled with a variety of topical medications, are where these medications provide the greatest benefit. Medications like dupilumab have been approved as young as 6 months for treatment. So again, a wide-ranging variety of age groups. But the mainstay is, again, patients that are severe and not controlled with other treatment options or modalities. So we have omalizumab, which targets IgE, is used primarily off-label, but again, being studied for atopic dermatitis. We have dupilumab, which again blocks IL-4 receptor alpha, which reduces skin inflammation and improves the skin barrier, decreasing the flare-ups. Again, decreases IL-4 and IL-13 specifically. And then we have tezepelumab, which targets TSLP. And then we have treponlimab, which specifically blocks IL-13. And again, these are the current biologics that are, again, approved in treating severe atopic dermatitis. Again, targeting those type 2 inflammatory markers. Okay. Next clinical state. So we have chronic rhinosinusitis with nasal polyps, characterized by inflammation and growth, leading to congestion, loss of smell, and difficulty breathing. Similarly, characterized by, again, the type 2 markers of IgE, IL-4, IL-5, IL-13. Treatment, again, similar to other conditions where severe persistent symptoms despite treatment with topical steroids or need for recurrent or oral steroids, or frequency of nasal or sinus surgery is when these biologics are usually indicated or considered. Additionally, we have comorbidities associated with chronic rhinosinusitis. So individuals also have asthma or tend to be more refractory in disease, as well as, again, the category of aspirin-exacerbated respiratory disease, or what was known as Samter's triad, have more frequency of nasal polyp reoccurrence. And these individuals or patients also seem to benefit greater with treatment with current biologics. The specific targets, again, for current treatment, dupilumab, which targets IL-4 and IL-13 through the IL-4 receptor alpha. Omalizumab has been now approved for treatment as well, targeting IgE. And then we have mepolizumab and benralizumab targeting IL-5 for the eosinophilic inflammation and reducing the eosinophil levels. Again, all of these biologics help reduce or shrink nasal polyps, improve breathing, sense of smell, and decrease the need for surgery. Next one we have is eosinophilic esophagitis. Again, this manifests as dysphagia or food impaction for most individuals. Again, sometimes associated or triggered by food allergy. We have inflammatory changes that are generally seen on endoscopy, which showing some linear furrows or edema or narrowing of the esophagus. Again, driven by the same inflammatory mediators of IgE, IL-4, IL-5, and IL-13. Indications for treatment for biologics, again, refractory to standard therapies. Individuals who have high levels of eosinophils on biopsy, have multiple food allergies or need for oral steroids, as well as, again, frequent dilation of the esophagus. Again, most of these are considered severe patients. The differences with chronic rhinosinusitis and eosinophilic esophagitis is that these treatments are actually now more preferred because they are much more effective than some of the topical treatments that had been used previously. Currently, the only approved treatment for eosinophilic esophagitis is dupilumab, which targets IL-4 and IL-13. But multiple biologics are in clinical trials, again, targeting the specific markers or cytokines that we've mentioned, and are seeking approval for this condition as well. And I won't be surprised that we will have some additional medications in the near future. And so almost through the home stretch, we will now go over a little bit on food allergy. Again, adverse immune response to specific foods involving IgE typically leads to symptoms from hives and itching to severe symptoms of anaphylaxis, including drops in blood pressure. Food allergy, again, has a significant impact on quality of life across all age groups. The main difference here for food allergy compared to the other conditions is that this targets or is usually manifested by mast cells that release histamine, versus more of the other conditions were based on those eosinophils and cytokines causing inflammation. Skin symptoms, GI symptoms, respiratory issues can all be present in anaphylaxis and require immediate treatment. Currently, we have, again, most recently, medication with omalizumab, which was approved for treatment in reducing the risk for anaphylaxis from accidental exposure or consumption in pediatrics older than 1. It is also currently being used in conjunction with oral immunotherapy to reduce, again, the risk of anaphylaxis for individuals who are undergoing immunotherapy treatment. This comes, again, directly from the New England Journal that was published earlier this year, where we can see that the treatment arm of individuals with omalizumab versus placebo were able to tolerate a greater number of patients were able to tolerate a higher threshold of consumption of specific food allergens. So we can see here that patients who were given omalizumab, 67% of them were able to consume a higher threshold of peanut compared to the placebo arm. And again, across all of the different food groups that were tested or evaluated, omalizumab created or provided a greater level of protection with regards to reducing that risk for anaphylaxis. And so just to summarize, we have a lot of key similarities. Hopefully I've outlined a lot of the central components to the treatment for these conditions, all around type 2 inflammation, which again is manifested by the cytokines that we've talked about, IgE, IL-4, IL-5, and IL-13, as well as, again, eosinophils and mast cells that are the specific cells that are involved in the type 2 inflammation. These treatments are all indicated for moderate to severe cases that have been refractory to typically other treatments. They generally improve quality of life significantly, reduce the need for oral steroids, again, decrease hospitalizations, surgeries. And as, again, the treatments expand or we get more clinical evidence, they may be approved for lower levels of severity. And as future discussion, potentially even things like remission for disease states are being considered. So just as a final summary and conclusion, biologics, again, target key molecules driving inflammation. They offer more personalized treatment across asthma, atopic dermatitis, chronic rhinosinusitis with nasal polyps, eosinophilic esophagitis, and food allergy. By addressing the specific underlying immune responses, these biologics improve patient outcome, reduce the need for steroids and other traditional therapies. And I want to say thank you for joining today's webinar. I hope you have a clear understanding of how biologics work across these various allergic conditions. And we will now open it up to any questions.
All right. Thank you, Dr. Merchant. That was a lot of information. It was great. I learned a lot. So thank you for all of that. So we have some questions in the Q&A. And the first one is, excuse me, the person states, I have severe asthma and my doctor has suggested these biologic drugs. My asthma is well controlled by the traditional drugs I've been taking, and I have been told that biologics can cause an anaphylactic incident, which is the reason I have resisted taking them. What's your opinion on this?
Yeah, so most of the drugs now, and especially with the more, what are considered fully human antibodies, like dupilumab or benralizumab, again, have lower risk for creating an immune response, including, again, producing IgE against those specific drugs that cause anaphylaxis. So the overall risk for anaphylaxis is relatively very, very, very low for these, again, fully human antibodies or monoclonal antibodies. The initial concern with omalizumab specifically, because that was, again, a humanized antibody, did develop or had a little bit of a greater risk for anaphylaxis. The risk is actually not that much greater than what we see with traditional immunotherapy treatment. And most of the medications, especially as a result of the pandemic, where injections could not be administered in the office, were now developed to be administered at home with some precautions for managing anaphylaxis, but again, generally safe enough that they can be administered home with a very, very low risk profile. But the newer, more human antibodies again have again very low risk for anaphylaxis.
Yeah. And Dr. Merchant, I've heard that a lot from not just this person here on the webinar, but from other patients. They're afraid of them. There's a fear of biologics. And I think that, if they're explained better, and I'm sure that you do that in your office, just kind of giving them a real basic understanding of what biologics are, they're more apt to, want to try it and not fear it as much. But I do hear that a lot.
Yeah, I think again, as all treatments, again, we sort of continue to learn to understand, what the risks and benefits of medications are going to be, where they're going to be most appropriately indicated. And again, I think, traditionally, before most of these medicines have been approved over the last, 5 years, most individuals or patients, especially with asthma, were on oral steroids, chronic oral steroid use. And again, a lot of these treatments, again, we can get off of chronic daily oral steroids, which again is very important. We know that daily oral steroids have a lot of risk factors. And then the other piece that we, again, sort of sometimes don't think about, even with the topical steroids, is that when we think about nasal steroids, inhaled steroids, topical steroids to treat the skin for atopic, again, that's a high steroid burden that we place on patients over a long period of time. And so biologics, again, ultimately decrease the steroid burden, whether it's oral or multiple topical steroids that are currently used based on the different comorbidities. We can, again, target very specific areas that have multiple areas of benefit.
Mm-hmm. Okay. And the second question is, how do you know what type of asthma someone has? Is this determined with blood work?
Yeah, so there's a couple of different components. It all starts with the history of, asthma symptoms, and then looking at whether they have allergies as a component or trigger, looking for that IgE target, blood work to look at that eosinophil count. And those are the primary things that we sort of look at. We can also use fractional exhaled nitric oxide as a marker for eosinophilic asthma versus non-eosinophilic asthma. So we have a couple of different markers that we would use to try to, determine or help us to classify, where their asthma is within these new categories of asthma definitions.
Okay. Another question. I'm seeing that physicians are prescribing COPD patients with Dupixent, as I generally thought these were treatments that were closer for asthma. Is this new? Are there biologics being tested for treatment of COPD?
Yes, so great question. Dupixent was, again, most recently approved over the summer for individuals who have type 2 inflammation and COPD as a component of their disease. So they either have a high eosinophil count or, again, other features that would help target or where Dupixent would be beneficial. There are biologics that are being looked at for similar indications among the ones that are currently available, as well as, again, new ones that are being targeted for some of those other inflammatory pathway targets that are now identified. So there is a lot of work going on in the field for COPD, as well as ongoing work for in asthma. Currently, I think there's about 2 or 3 additional biologics, again, targeting various inflammatory markers in asthma, as well as, again, multiple studies that are being done in COPD to see if we can get better targets for treatment. And as mentioned, and we'll talk about over the years, is do these biologics help to put individuals into remission? So not just treatment, but remission states for conditions like asthma.
Okay. prurigo nodularis also involves type 2 inflammation. Are biologics ever used on or off label for this? And is there a reason they could not be?
Yeah, so it is a condition that is treated with, I believe dupilumab is approved for this indication as well. I didn't focus on it tremendously because, again, it's not a large population that I see. But biologics, again, are being looked at across all of the type 2 inflammatory conditions, including prurigo nodularis.
Okay. Now, this question has a lot of acronyms, Dr. Merchant, and I'm sure you're going to know what they are because I don't. But with the new PDE3 and PDE4 inhibitors and approved for COPD, do you see it being used with IL-4 and 5?
Yeah, so PDE 3 and 4, so those are the phosphodiesterase treatments that are available or now approved. As again, we get more specific treatments and we sort of understand the combinations of different pathways for inflammation, I think we will get more clinical experience on which drugs or combinations of drugs will work over time, similar to how our current combinations for COPD with a long-acting beta agonist, an inhaled steroid, and a long-acting muscarinic agonist, so a LABA/LAMA ICS combination. I think we will continue to evolve how we put these different drugs together or in what combinations to provide an optimal response.
Yeah. So one question here, and I'm kind of going to add on to this question so you can maybe hit both of them at the same time. The question is, how long do you continue and when do you consider stopping biologics? So I'm thinking, if you're on it for asthma or atopic dermatitis or any of the disease that biologics are intended for, I guess, the question, if you start it, is there a way that you can stop it and kind of go off it because it's getting better, or is it like lifetime?
Yeah, so again, great questions. I think because these medications are, again, so new, we don't have, again, sort of that historical longevity of like, how long is treatment necessary for? Typically, what I tell individuals and patients is that, these treatments will help make you feel better because most of these individuals are uncontrolled. And then like every other treatment, we sort of monitor to see how long do we think we want to consider treatment for? Most of the clinical studies, went for about a year on treatment. And then there were a lot of extension studies to sort of determine, ongoing needs. And so I think we are still trying to, come up with ideal recommendations for duration of treatment. I certainly wouldn't consider, treating a 1-year-old with lifelong biologics, for atopic dermatitis. Some disease states have some natural progression for remission. And again, I think as we learn or understand how remission for inflammation may work over time, that we'll have a better understanding. Typically, I recommend, like all treatments, especially for asthma, is that after a period of stability, you look for de-escalation, and whether that de-escalation is reducing the inhalers to begin with or stopping the biologics, again, are parts of shared decision making that we sort of have to look at on an individual basis.
Okay. Do biologics contain blood fractions?
I'm not entirely sure what that refers to in terms of blood fractions. So specific, blood products like immunoglobulins come from whole blood and then are separated to contain only purified immunoglobulins. So if it's a part of blood, then yes, there are certain biologics that are that come from blood products that we currently use. The monoclonal antibodies are not, in that category of a blood fraction. These are, again, genetically engineered. The fully human antibodies are genetically engineered. They are created in laboratories, for administration. The early models, again, were where these antibodies were generated in mice and extracted from mice, for administration, may be considered a blood fraction because, again, they had to be extracted from the serum. But the current technology and treatments, don't involve, direct blood.
Okay. And here's kind of like a two-part question. Are biologics effective to treat allergies? And if I am taking an allergy shot, are they still needed? Do I need to still get the allergy shots if I start biologics?
Yeah, again, great questions. Generally, again, current biologics, specifically omalizumab, has been used off-label for treatment in conjunction with individuals receiving allergic immunotherapy or subcutaneous immunotherapy, where they've had experienced a severe allergic or anaphylactic reaction, again, to reduce that risk of anaphylaxis associated with immunotherapy. I think the key difference between biologics and immunotherapy is that the immunotherapy is, again, stimulating the immune system to sort of change the inflammatory response to be more protective, versus the biologics are targeting those markers for inflammation to reduce that inflammatory state. And again, both are currently used in combination, again, off-label, both for oral immunotherapy and subcutaneous immunotherapy, to, again, reduce the risk for anaphylaxis. And I think we will learn with time, again, how these medications, if one option is a better option or not. Again, immunotherapy traditionally has been around for, again, a century, and again, works extremely well. The other key piece, and again, I didn't really talk about it, is that biologics are expensive. These medications cost, several $1,000s. And so we don't jump through them right at the beginning, because, again, it would bankrupt the systems that we live in with regards to the cost of medication. So if we treated 25 million asthmatics with biologics, we would be spending, well over, all of the treatments for, allergic conditions. And so there is a place where biologics provide a tremendous benefit, but cost is always a factor. And we try to balance those pieces. And our traditional treatments are very cost-effective options and work well, with good adherence and other considerations.
Yeah, I was going to say that was one of the questions in the chat about cost, because they are expensive. And I would just add on to that as well, just depending on what kind of insurance you have. I know, some people get their insurance at the, transition years, and they don't bother to check to see whether or not they're approved, but this is a specialty drug. So it would just behoove you to just kind of go through and look at your insurance coverage as well. Just adding on to what you said, Dr. Merchant. But that was one of the questions in the chat, that and access to biologics.
Yeah, I think biologics, again, they do have good access. They do have good coverage when you have insurance. There are, again, programs that help to provide access from most of the pharmaceuticals for, again, patients that really would benefit from it. And so, again, I think as we continue to have more medications available, I think, again, cost likely will continue to decrease over time, both based on, again, the ability of the technology to reduce cost becomes cheaper, and, again, competition among pharmaceuticals will, potentially drive down cost as well.
Okay. One of the questions here, are all biologics all injectable?
Yes. So biologics, again, because of the complex, molecules that are involved, are all, injectable. So either an IV or subcutaneous injections for all of the monoclonal antibodies.
Yeah. I think you went over this, but I think it's worth repeating. One of the questions is, what are some of the common side effects of biologics, and who should not be prescribed them?
Yeah, so the most common side effect, typical with most injections, are, pain, redness, swelling, at the injection sites. These are usually, again, very mild symptoms that are experienced, and depending on the frequency of the injections, some of the biologics are administered every 2 weeks, some are administered every 2 months, and some of the newer ones are even looking at every 6 months. So again, those are generally the most common side effects. Again, a very, very small risk of having anaphylaxis to some of the biologics, not all of the biologics. And so if there's been any previous history of having anaphylaxis to a biologic, then obviously that would be a contraindication, to potentially using a different, a biologic. But again, that's not an absolute risk to say that, if you had a reaction to, say, an IL-5, monoclonal, that maybe you would have a similar risk to, an TSLP monoclonal antibody. So I think we're still learning on some of those, but that's always where we would be most cautious of having some sort of severe adverse effect, to then be able to say, well, do we apply that across all monoclonals or not?
Okay. One thing I just wanted to mention in the chat, if you are interested in learning more about biologics, there's a link there that you can click on and you'll learn more about it, as well as an insurance and access webinar that we have there that you can kind of take a look at it, because I know there were a lot of questions in the chat about that. One other question we have, Dr. Merchant, what is the risk of immune suppression and cancer with biologics? I know this is a major concern for people taking biologics.
Yeah, so as with, again, any manipulation of the immune system, we are always trying to be aware of sort of the unintended consequences. Most of the biologics, before they even get to clinical trials, for consideration, have been weeded out to say these side effects or these parameters are not things that would warrant further development of the drug. So the current ones that we have gone through a pretty rigorous process to look at the overall benefits and the targets, and trying to make sure that there are no unintended significant consequences. So cancer has not been identified particularly as a risk factor. Omalizumab has been, again, around for about 20 years, and we've not seen a specific increase or risk for any major organ problem like liver, kidney disease, or anything associated with cancer. Depends on the target. Again, the more target the specific the monoclonals are, the less likely for broad, severe implications, versus, again, oral steroids or steroids in general, again, are highly immunosuppressive, especially at high doses where we block everything, and again have greater risk for infection. We see less of those issues with most biologics. The biggest risk factor for infection comes from blocking that IL-5 pathway and eosinophils, which are typically used to fight parasitic infections. Again, not generally a major concern for, again, us in the US, but certainly in other countries, parasites are things that we need to be aware of. So if there's a travel history or something, we want to be a little bit more aware of that risk factor of parasites, being more likely to maybe cause problems if we have suppressed that eosinophil pathway.
Okay. Dr. Merchant, you had a slide up, very informative slide where you listed all of the MABs. I'm just going to call them MABs for short because I have a trouble pronouncing the whole thing. But the MAB slide that you had up kind of listed what it was and what pathway it was intended for. And this question is kind of interesting. It says, have any of the MABs been used together in combination to cover different pathways? Or do you know of any studies that's happened?
Yeah, so I don't know if there's any specific clinical studies that have looked at those different combinations. There are case reports and case studies that have been published where, again, one monoclonal antibody, didn't work, and where a second monoclonal antibody was used in combination with one. So there are case reports, and again, as clinical experience and expertise among clinicians and some of the academic centers for, again, refractory cases, come into play, there is more and more awareness that monoclonals can be used together and can be used safely. And again, may provide, again, a smaller subset of patients that didn't benefit from one or two, let's say they didn't benefit from two different monoclonal pathways, that maybe a combination would be beneficial. And so that is something that is, again, ongoing in terms of the overall, understanding of the disease pathways.
Okay. Dr. Merchant, this has been a great webinar, and I just want to give a special shout out and big thank you to all that attended, because everyone was so engaged, and I can tell by the questions that were asked. They're very thought-provoking questions, and really good questions. So thank you to the audience for joining us. So really informative, and just wanted to let you know that we have several webinars coming up in November and December. First of all, join us please on November 5th at 4:30 p.m. That's Eastern Standard Time for the next webinar for the in the Black People Like Me conference series, focusing on addressing COPD in the Black community. I can't tell you how much I'm looking forward to this one. We actually have a patient story that we want to share with you. So you'll get live experience with that. Really excited about that. And then join us on November 12th at noon Eastern Standard Time, when Dr. Michael Blaise will discuss remission of asthma and review the consensus statement. And on December 5th, we're going to welcome Dr. Purvi Parikh to talk about new developments in vaccines and how to address vaccine hesitancy. Now, you're going to receive an email from Zoom in a few days with the link to the recording and evaluation, really important. So please fill that out so we can make sure that what we're giving you resonates with you and something that you really need. And we're also going to have supplemental resources. So with that, I just want to say thank you again from all of us at the Allergy and Asthma Network, and join us always as we work every day to breathe better together. Have a good afternoon.
Thank you.